Hi, good morning, everybody. Welcome to the 12th episode of the Health System Fix podcast. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health systems expert. Through this podcast, I hope to talk to people who bring different expertise and different views of the health system. We talk about health system gaps and also what fixes are needed. I'm very excited to welcome Deena Berry today. Deena Berry is the Assistant Director of Risk Management at UC San Diego Health, where she oversees clinical risk operations, professional liability assessments, and policy development. She's also a co-author of the ASHRM Medical Office Risk Management Playbook, published in 2025, which is a large organization working on risk management in the medical industry. Most recently, Deena also launched her own consulting firm, EMMURJ, dedicated to helping healthcare organizations strengthen patient safety, reduce legal risk, and build sustainable compliance programs. She has more than 25 years of experience across hospitals, rehab centers, federally qualified health centers, and brings a wealth of knowledge in risk management, patient safety, and regulatory compliance. Fun fact, Deena and I worked together for about 2+ years at San Isidro Health between 22 and 24. Welcome, Deena. Great to have you on. One of the ways I wanted to get to know our guests is start with early life. What was life like growing up till you start thinking about college and professional careers?
Was born, I'm a native of Southern California. I was raised in Riverside County, specifically in Hemet. Graduate of Hemet High School. Go Hemet. Don't know if anybody knows where that's at, but go Hemet. Childhood for me I was a pretty strong-willed kid. So I had a few, turns here and there, but overall, my journey toward independence started when I was 15. My mom would just tell you I didn't like following the rules. But I think at that point in my life, I was simply starting the process for advocating process improvement. And so that to me was kind of where my risky journey began in my true fashion. It's something that I didn't follow every rule. And I always felt like there was always a way to look at things differently. And so, yeah, my they taught me a lot. Let's just say that.
Straight shot from there to risk management and healthcare. You're
Pretty much.
not taking how things are done as an answer. Tell us a little bit about college experience. Or what was experience that brought you into healthcare as a field?
So interesting enough, college wasn't on my plan either. So college actually came later in life for me. I spent probably about 12 years working at a law firm. I was a mama at that point, and so I needed to work. And so that's kind of what pulled me into the law firm, worked there for 12 years, and then decided I had to make a change. Really didn't have any direction of where I was going, but I was kind of just trying to find myself and landed in a position in an acute care hospital working with medical staff services. And so that kind of started from there. Went from medical staff services, quality, compliance, regulatory into risk management. And so once I got into risk, it kind of built on the legal learnings that I got from the law firm. And now I was able to bridge that into healthcare, which for me was an environment that I really grew to love because it was constantly changing. And so I found kind of stagnation at the law firm and I couldn't figure out which way to go. And so moving into healthcare, I really felt like it bridged and it was constantly evolving. It's constantly challenging your thought process. Nothing's the same. Every day is a new day. For most of us that, work in healthcare, you kind of know every day is never going to be repeated.
Right. Obviously, in risk management, you work in the legal frameworks, you work with attorneys. What were the few things you feel like you really picked up or learned working with a law firm or within the legal sector that were great lessons for later for healthcare?
I think that it was investigation. storytelling, right? In legal, when you're working on a case, you have to put all the facts of the case together. And so that was something that as I, worked on cases or I assisted in processes, everything on the legal side was very in order. Something occurred at this time, and then what's the next step? And so when you look at risk and patient safety events, it just was a perfect fit because I'd already learned that process. And I'm a process thinker, so everything for me, I like to know from beginning to end because I figure if I can have a good idea of what's going on from beginning to end, I can now kind of pull apart to find out, okay, where was there an improvement? Like where could we have done better? And so that was a big learning from the legal side and bringing that into risk.
You know, so much of this is making sense because I remember when you joined San Isidro team, I was already there for maybe 3 years. And it was for the first time I felt, as you're saying, that healthcare, so much is changing all the time. Even if you have a perfectly running program, the next patient who walks through your doors could have something that you're not just a diagnosis, but their life circumstance, which is often more often likely the case that is kind of making the variation. I immediately, I think when you started working there, I immediately saw, oh, this person knows how to organize all of this chaos into a story that now to me as a clinician is making sense, as in the flow of the story and where are the gaps and what was done well or not. Yeah, it was an incredible experience working with you. And I think, as you're saying, that the experience in the legal field helped you organize that information. When was the first time you started getting interested in risk management as a profession, or something that either you found you were really good at it or was something that you found interesting to work in?
For me, again, it was a development that happened. Once I saw like how risk worked in healthcare and that I could bring my legal experience into it, I felt like, oh my gosh, I really like this. And it's a constant change. But where I felt like I could lend assistance was because I can look at a process, I can pull it apart. Felt like I was able to partner in healthcare to improve, right? And it's not just improvement for the organization, but it's also improvement on how we deliver care and services. And so that to me was rewarding, talking to patients and families. Risk gets sometimes, I always say, we don't get the butterflies and rainbows, but we get the thorns and thunderstorms sometimes. And so I think it's nice when you can go in and kind of have some human connection with the patients and the family and hear their side of the story because a lot of times we just assume, it's our team, everybody's correct. But sometimes, I've learned our team has bad days. And so how we interact with our patients matters. And to be able to hear them and be that, you know, be able to be a resource for them to allow them to communicate what their experience was also, beneficial. So that was for me was like, okay, I like this. And I was willing to now expand. So that meant how do I get better in risk and how do I start um making this a career? And so that's where once I found that niche in there, it just kind of evolved from there.
And you have worked in so many different healthcare settings, right? Even prior to San Isidro, you were already worked in large hospital systems, and now you're back in one. So I wanted to ask you, across different systems as you worked, what were the key differences and how risk management was approached?
So, yes, I've worked in acute care hospitals. I've worked in acute care inpatient rehabilitation hospitals. Going to San Isidro, I was working for an FQHC, so your community health centers. And that was, I think, the biggest change or wake up for me was going from the hospital setting to the ambulatory care side. And what I found risk is risk to me wherever you go. Like if I'm in a hospital or if I'm at an ambulatory care, there's risk in both. And the risk is the same. There's incidents, there's things that happen. The greatest difference is the how it's operationalized. And so on the hospital setting, I think there's more emphasis a lot of times with risk that because there's Joint Commission, you have CMS, your state, in California, you have CDPH who comes out and they're auditing you pretty frequently. I think you have more stringent reporting requirements as a hospital. I found once I got to ambulatory that I wanted to report. I was programmed to report. And so, but I found that with on the ambulatory side, it was quite the same. And so I think that was a big difference and just how it's operationalized, and that there was less emphasis on reporting requirements on the ambulatory versus on the hospital sides.
I'm just thinking as you were answering this that, if two people are hospitalized and let's say both of them are in the ICU and both of them have a serious lung infection. So from a medical standpoint, they're identical. In that setting, all of the processes, procedures in treatment is so standardized that what each of their lives outside are may have a little bit less impact. It does have an impact, obviously, and it should be considered. But maybe how the hospital itself runs has less of an impact in that individual patient's care. Whereas an outpatient, people are coming in off the street from their homes, wherever they are. So they're bringing a lot more of their current life into that setting. Does it lead to the clinic systems needing to be a lot more flexible in how they do things? Not that should all be, haphazard, but at the same time, maybe do you think it requires more flexibility in how things are done?
I do see there has to be some flexibility for the clinics based on the community. We'll just take San Diego County. So you could be on one end, on the south end of the county, and the need is different than maybe on the north end of the county. And so I think there has to be some flexibility given to the clinics to know, understand, and be able to function to meet the needs of that community. But I think as an organization, we sometimes give too much flexibility. And I think you have to have a foundation. We can say how we respond to certain codes. There has to be a foundation of when we call a code, how is it going to get responded to? The flex is in you work within the parameters of that clinic. So what staff respond, where you show up to, there has to be flexibility in those areas, but you still, as an organization, a foundation, a beginning to each of those clinics, if that makes sense.
Yeah. That makes complete sense. I think that's definitely, I agree with that. I wanted to ask you, and this was, again, one of the joys of working with you is, a lot of times previously, at least, that I interact with the risk management team, I think that the approach was often too conservative. And the kinds of patients we are seeing in our community health centers today, they are coming in with complexities way beyond the medical diagnosis. So the approach, as you said, there needs to be a baseline and there needs to be some flexibility around it. I think one thing that you did well, and that's, I think, the reason I feel like we worked really well together was I think we were approaching a complex clinical situation which didn't always have set risk parameters and how do you quantify this risk and how do you mitigate risk. We were coming at it from a point of view of let's make this work for our patient. So have you seen a lot of very conservative approach, and how did you not go that way but differently?
I think life kind of developed me to just look at things a little differently. So I think there are some that have a much more conservative approach. I'll be honest, when I first came into risk, I've had some coaching along the way, to improve my delivery because I was very it was very black and white for me. Like, you don't do this. And over time, I heed what I'm told. Like, if you're giving me feedback, I take that to heart. I listen to, what, I could have delivered that better. Or what I did realize, this is a big learning within risk, is that the policy may say something, but you have to get down to how are things on the front line. Is that realistic? Just because it's a policy doesn't mean that it works. And so I think for me, what I learned over time was that while we have a policy, and yes, we've got to follow the policy, I get that, but you also have to see it in play. So you have to see, does it really work? Or if you get into that and you go, I like to be hands on. So I like to see things in action. And if you go in and you find out, you know what, this policy, the way this is written and what our current environment is, it doesn't work. We got to fix that. And so I had to change and recognize that a lot of times policies haven't been updated, they've just been reviewed and haven't been brought to the current state and account for certain things. And so it's important to take a step back and go, okay, no, they didn't follow the policy, but let's kind of peel this back to see, where there's some improvement and take a more humanistic approach to that. As I started to do that, I realized that's how we partner. Risk can't come in and just be the police of a hospital or, a clinic setting. We have to come in and our purpose is, let's say the old school risk was we're reactive, right? We react after it's all happened and now we want to come in and tell everybody what to do versus an enterprise risk management system is we want to be proactive. And so we want you to put in your incident reports because if we can identify trends of things that are going on, it's going to help us get to how do we improve that process and working and collaborating with the departments and the teams.
Yeah, it was surprising for me that risk was one of my favorite areas of work as such. Either I did not expect it to be when I first encountered it, but I think it was really interesting to have both the risk and the clinical teams who were very invested in trying to make this complex situation not just say, oh, we can't see this patient here, which is a reactive thing. Oh, this you shouldn't be doing this, but really make it work for the team and for the patient. And I'm also glad that I was able to pass that along to Dr. Oja, who took over from me, that told her, it's now her favorite meeting also. So how would you recommend risk management teams and the clinical teams? How should they work better together to develop this partnership that can then it impacts everybody, impacts the organization's risk level, impacts patients' access to care, impacts the front line. What would your recommendation or advice be for both those teams?
I'm not here to tell you how to run your department. That's not my job. What I am here to do is to bring awareness of, hey, I see this trend or hey, this event occurred and here's maybe some opportunities, right? How you frame your questions matters too, that you're not coming at someone or a department, that you're really there to partner. And so, how can risk support, right? How can we work with you to help develop an improvement plan? Um, and this is something else that I've learned over time, like improvement plans, everybody's got a lot to do. And nobody wants an action plan. So you have to work on making it lean in the sense that you're not just overwhelming the departments and they just feel like you're there to just give them a lot of work. But you're actually invested in creating actionable plans that are going to help show results. Education, that's another area. I think it's important that our risk teams don't just come in, oh, you got to just file incident reports, more incident reports, and more incident reports. But explaining why incident reports are important. I just recently did a presentation with nursing on the functions of risk management and how to document, like make sure your documentation is in alignment when it comes to a behavior issue. And risk can partner, provide education, and really just work to be a team with the entire organization.
We're actually 100% aligned. Both of our goals are the same, provide great care and not cause excessive risk for the organization. And I think being able to have that communication openly, and I remember I asked for your opinion and I questioned it, and you asked for mine and you questioned it. And I think that it is not offensive to either of us, because that's the dialogue that needs to happen to get to this place that works for the organization, for our patients. And I think slowly, as confidence built in me, I also used risk as a resource to process improve. There were some new projects we were working on, which we were having difficulty streamlining the processes because they were implemented in 3 clinics and all didn't have standardized procedures or space or people. So the risk team came in and did a study. I actually told them, just look at it, how it's done, because I wanted to know this from my internal partner versus an external audit that tells us we're not doing things right. And that is incredibly valuable also as just a clinical team trying to make a new thing work that we don't necessarily know how to do all the way, but it helped us frame our policies, procedures.
And risk can help with completing a gap analysis for a new system comes into play, and we can do a failure mode effects analysis. And so there are tools so that we don't get looped in at the end. And then we have a lot of questions because there's a lot of things that aren't considered. And our voice, a lot of times, is we're asking the hard questions for not the right now, but the down the road. Okay, so you're putting this process in. How do you respond in an emergency? And that covers how you're going to have to respond to the state or regulatory agencies. And so take the lens of what happens when surveyors come in? What happens if we get a complaint? What happens if we get a lawsuit? So we have to be that mind that's forward thinking about what's next. And so it's definitely important to loop us in. Sometimes we'll sit there and maybe not say anything. Maybe everything's great, but at least we're able to hear and provide some feedback if it's needed.
It's funny because generally everything is not great, so we need help. I know you've recommended the ASHRM risk management course to me, and I'm not done it yet, but it is on my to-do list. Are there courses or trainings that you'd recommend, maybe somebody who's in risk management, right? Or somebody who's a clinical leader who doesn't understand the space well? I'm guessing ASHRM would be one course that you'd recommend maybe to a clinician to sort of expose themselves to the world of risk management. What other concrete steps or courses can people take to really become more knowledgeable about the space?
I think ASHRM is a great start. But if you're really going into risk management, I would say find a mentor because you have to really know if you're cut out for risk. And I said earlier, it's not a lot of rainbows and butterflies. There's a lot of you're carrying a heavy load and you may come in with this perfect little to-do list for today and you don't see that to-do list again for another 60 days. And so what's happened in between time is the reality of it. So I think if you're starting off, you first have to establish whether it's really a good fit. And even if you started off as a risk coordinator or an analyst within risk, partnering with your leadership or go to some networking events, find your local chapters and talk to people, see if it's something that you're wanting to do. And if it is, then I would say let's move into getting your certification and making that investment. I think when you had brought up getting your certification, I completely salute you because I don't think I've ever had a physician tell me I wanted to do that. But I think it's invaluable because you're at the front line and you're leaned on from all different directions, from your staff, from the executive team. It comes from different directions. And to be able to incorporate that knowledge base of risk, it really helps you. It helps you to see things a little differently or ask questions that maybe as a physician you wouldn't have asked at one point in time. And now it's kind of expanding. I think the first steps are to really explore if it's something that you want to be in and start working in that role. And that can be just an entry level position and then mentors and then moving into the certifications.
And for the clinical leaders, they should start talking to the risk management leaders because sometimes we are very hyper focused on this one patient and injustice, and the landscape of things to consider is way too broad. And I think it's important to have a place where you can actually think that broadly. And somebody who's in risk management team who's not had a traditional pathway through clinical, they need to spend some time in the clinic. Just be in that environment. I think educates you a lot about how things are happening. Goes a long way in developing as a leader.
I I had an employee before who was like I'm gonna be this, risk manager one day. And so I brought them in, to start at the as a coordinator, and they were like, forget it. That was not for everybody.
And gung ho may not be the right energy because when most settings, when you hear from risk, most people are not excited to hear. I was happy to hear from risk, but I think most people are hear from risk when there's a problem. So they're not, oh my God, this is amazing. Let's talk about this. Right? Maybe gung ho energy is not not how to lead to that. Let's talk about your first leadership role. I've seen this also. Your skill set as the clinician, as expert in your space, is something else, and then leading a team is a whole other skill set. So what is that first leadership role where you're overseeing a group of people, and what was that like? What are the challenges?
So my first run at leadership is when I stepped into a role with an acute care inpatient rehabilitation hospital. And so I came out of being an analyst, went into that role, but it was dual. I was a director of quality and risk. And so I had to tap into what I'd learned from the quality world. It also oversaw medical staff and the risk management side, which for me, they all work together. And there's parts and pieces that you need in that, that triad there. You're going to see risk. Risk is in everything, but risk does not own everything. So that was my first leadership role. And when I stepped into that, it was a brand new hospital. So I also got the opportunity to open a hospital, which was very enlightening because had never done that. Not only was this a new director's role, but it was also new. This space was new. It was brand new build, opening the doors and going through all the regulatory surveys. And we opened it right when COVID happened. So I had a whole lot of learnings through that entire process. But as a leader, for me, I want my team to be successful. And that was something just in general, I want to see people succeed. And so I've had, the ups and downs of leaders that I've worked under. And so I took some of those things and applied, like, I don't want to be this or I don't want to be that. And so have some hits and miss. And it's just been a growing experience over time and learning that it's a team. It's about a team. It is not about me. I'm just there to share my knowledge, and because it's the team that I'm leading that's really carrying the weight. And so I want to make sure that I'm supportive in what they're doing and giving them all the tools to be successful as we go.
Yeah, I think the hits and misses at point very well taken, because I think sometimes I've seen leaders be incapacitated by, is this the right decision or not? And I tell them, for sure, some of your decisions are going to be wrong. There's no way around it. And if you take 20 decisions, maybe 10 are wrong, 10 are right. That's a good number. So that's not a failing rate at all. And initially, you feel you're it. You're making sure everything happens. And maybe a couple years in, you realize there's no way you can make it all happen. I realized that maybe 2, 3 years in that I was thinking of my vision. Then I realized, I've brought on so many amazing people, many of whom are better at so many things than I am. It's no longer my vision. It's a collective vision, and it's all on them too, as much as it is on me. That was very relieving also, to like have team members that you can rely on and be okay with them failing and there to support them, right? So that whole journey is a critical journey that leaders need to take, and you have to do it to grow as a leader yourself. I want to ask you about policies. By the way, I've never used the word beef in my life, as in the context of the beef I have with policies is that they are too broad, too generic, as I think you pointed out. And I get the logic that they need to be applied to many different settings. But at the same time, I find that that results in lack of standardization that you would want in a large organization. What is your take on policies and how should they be written?
Being recorded, right? Um, Policies. Yes, policies are the bane of our existence. I find because policies, they were there when an organization started, they've evolved, and they change based on who's in position at the time or don't change based on who's in the position. And so I think the broadness is because you don't want to pigeonhole yourself for change. If we get real specific, those are what I call the low hanging fruit for surveyors to come in and tell you, you fail, 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 right? I don't like very wordy policy. I find wordy policies is where it also opens you up. In prior organizations, I would see stuff, they got specific down to paper clipping this to the top. And I was just like, oh my goodness. And so it's important as leadership, learning how to review as you come in, even as a new leader, coming in and being aware of what policies are mine. And what needs to be changed or updated? Because a lot of times we go right into the fire, and so we don't have time to sit down and read, but what ends up happening is as you're in the fire, you start asking the questions, "Why did you do that?" Well, because that's what the policy says, or they think it's what's in the policy, right? And the policy's changed 5 years ago. So So policies are supposed to give us guidance, but because we end up with so many requirements, regulatory requirements, state across the board within healthcare, we just don't have the time to sit down and review. But we definitely need to work on leaning out and creating a space that if it's, we'll just say a disruptive behavior policy. If it's a disruptive behavior, you have kind of the framework in the policy, and the procedure, which is the execution at the clinic level, they develop that procedure. So you have some of the overarching framework, but the procedure itself is at each of the clinic levels. So you give them room to build on that.
And I've seen the policy with a lot of words. I didn't know what it meant after I read those 4 pages of policy. So how am I going to actually do it? It doesn't say. So I like that idea that, the organization has a policy, and then because each clinic site may have its own specific needs, each clinic site then develops a procedure that aligns within the policy, but then works for that. I'm guessing it could then be approved by the person creating the policy, so that it is uniform.
Another thing too is I've seen policies that build for every scenario. And so I try to encourage or recommend to departments instead of building for every scenario, build your policy on the most stringent. So you don't build for everything, build your process to the most stringent, because if you do that, you're going to capture the rest of them. Like, so build to the one that, your process, if CMS has, a very stringent requirement that maybe the state doesn't have, as stringent, then build to the requirement of CMS so that that you're capturing all of that under that policy.
That makes sense. Okay. Tell us about your new consulting firm, Emerge.
So a lot of people reach out and, hey, Dina, help me with this, help me with that. And so I've been working with a company up in the Bay Area on developing their risk management program to partner with some of the counties um, county contracts up there. I just took this opportunity. I get asked these things a lot. So this is a business in its infancy, but it's been something that I've done over the years and just really hadn't put any teeth to it so I just decided this year that I was going to work on opening a risk management consulting within healthcare. So I've had some prior partnerships that I've done with physician offices. And so just giving them recommendations of what to do, what not to do. So that's kind of how it kind of birthed itself. And it's not my primary role and responsibility all the time, but my current role is pretty full. But I definitely, am always a resource, and so I've expanded into providing some consulting services. So EMMURJ is open and available for services.
And where can people find you?
EMMURJ.com, so that is EMMURJ.com. Um, you can go to the website, there's information on there, if there's assessments or policy review, there's, lots of little goodies. Check it out.
We're coming to a final question. What is the most, doesn't have to be the same. What is the most challenging and or the most exciting project you're working on today?
I think risk is just challenging. Risk is very, complex. My current role is is challenging in the sense that now I have married into acute care and ambulatory. And so now learning again a different structure, learning and working to develop that enterprise risk program, working in the space of, the acute and the ambulatory and several, hospitals. That's probably my biggest project. As I'm thinking about that, I'm like, "Ooh, that was a lot."
And it's almost like all of your experiences are kind of bringing it to this place where you're ready. You're obviously ready for it.
Yeah.
It's a pleasure talking to you always. I appreciate you joining us today. I would say probably more than 75% of the reason I got interested was because you were there at San Isidro, and we actually had a strong partnership in understanding those complex situations. And I hope more clinicians, venture in that space and understand it, because it actually makes how you think about clinical work for complex populations. It makes it a lot easier if you have a partner and understanding of the space. And same things for folks in risk management. Talk to your clinical leadership and ask to be in their clinics and shadow them. And I think really understand what it's like to be in the front line. It goes such a long way. Thank you so much, Deena. It is great to talk to you again. And good luck with your consulting and also your new role.
Thank you for being a partner at San Isidro. You were great because it was nice to finally feel like we had physician partners in the process that actually were invested to learn. And so it makes all the difference. Listen, risk does not want to make clinical decisions. We do not. We don't want to be the one to say that a patient is dismissed from care. And so we lean on our clinicians to tell us this is gonna work, this isn't gonna work. And so I applaud you for, investing the time and really understanding our process because it made a world of difference. And I was excited that, okay, we got somebody who's gonna partner for us.
I appreciate that. I think I remember you telling me, because I think initially maybe I also wanted you to make those decisions for us, and then later, 6 months in, I was telling my team, no, risk is not going to make that decision for you. So that was a learning curve for me also. Well, thank you so much, Deena. It's great seeing you. Good luck, and we'll connect soon.
Thank you.
Thanks.